Well, welcome everyone. I want to welcome all of our attendees, including our first timers and our returning members. Welcome all. And I also want to recognize our PBNSG team. Paul Chatlin, the founder of PBNSG, in the face of an amazing inspirational story of going from nearly dying to strong, vibrant, and healthy through a plant-based lifestyle. Marion Treese, Director of Operations, Brett Nyquist, Director of Technology, and Megan Burt, Director of Support Groups. We also have an amazing team of specialized hosts who each lead their own monthly support group meeting through our membership platform. As Paul Chatlin likes to say, we are together as one, and we have the same passion of helping others find success in this plant-based lifestyle. My name is Stephanie Spencer. I am a former cardiac RN. I used to actually run a heart failure clinic for 20 years. Turned plant-based educator, and now I teach online courses at naturalstateplant-based.com. I've been living a plant-based lifestyle for over 3 years now, which isn't very long compared to most people here. And nothing excites me more than helping pave the way for this plant-based movement and hearing the success stories and positive effects that result from this way of life. For those that are new to our events, PBNSG stands for Plant-Based Nutrition Support Group. We are a nonprofit organization dedicated to evidence-based education and advocacy of plant-based whole foods nutrition to help individuals prevent or reverse chronic disease and achieve optimal health. As you may know, PBNSG is well into our new membership platform, which gives access to live virtual events, cooking demos, support group meetings, event recordings, and more. Please pass along this information to family and friends, and more information can be found at pbnsg.org. Additionally, you can visit our website to find upcoming events, subscribe to our newsletter, and visit our shop page to order merchandise, which is where you will also find our perfectly plant-based cookbook, a curated collection of over 100 whole food plant-based no oil recipes by our more than 20 contributing PBNSG chefs. And please know that PBNSG will be offering whole food plant-based nutrition coaching for individuals who would like more support in this lifestyle. Please look for details very soon. We look forward to providing this additional level of support. And don't forget that our free monthly virtual community support group meetings are the second Thursday of each month. Registration for the monthly meetings can be found at pbnsg.org under support groups. And for those of you who use social media, you can find PBNSG on Facebook, Instagram, Twitter, TikTok, and YouTube. And so now I would like to introduce tonight's presenter. I am a big fan. I feel like one of the girls at the Ed Sullivan Theater when the Beatles came because I'm a former heart failure nurse, and Dr. Baxter Montgomery is a heart failure subspecialist. He's a subspecialist of cardiology called an electrophysiologist, which is a doctor that does super fancy pacemakers. And so he does this on a whole bunch of really sick heart failure patients. And he has really done a lot of work on investigating to see if nutrition can make as much of a difference as all these fancy procedures. Instead of just coasting to retirement doing his procedures every day, he's really a plant-based pioneer in the area of heart failure. So yes, a detailed discussion of several patients will be provided by Dr. Montgomery tonight regarding their initial presentation and clinical progress over time. Insights on the specific aspects of the nutritional intervention protocols that he does will be explained, and a correlation of the clinical outcomes will be made with our published scientific evidence on the mechanisms of action of the food. Dr. Baxter D. Montgomery is a board-certified cardiologist with years of experience in the latest medical practices and nutritional health. He is a clinical assistant professor of medicine in the Division of Cardiology at the University of Texas in Houston, a fellow of the American College of Cardiology, and a founder and medical director of the Montgomery Heart and Wellness Health Center, formerly the Houston Cardiac Association. Having seen many patients suffer the consequences of chronic heart disease, Dr. Montgomery founded the Montgomery Heart and Wellness Center in 1997 with the mission to reverse and prevent life-threatening illnesses. Located in Houston, Texas, the Montgomery Heart and Wellness Center is a state-of-the-art health center complete with all the technology and resources to provide comprehensive medical and wellness care. And they also have this amazing plant-based cafe there as well. Combining his medical practice with a food-driven lifestyle intervention, Dr. Montgomery introduces patients to a novel food prescription plan that helps reverse chronic conditions such as heart disease, hypertension, obesity, and diabetes without medications or surgeries. He has refined this process over the years with profound positive results in severely ill patients. Dr. Montgomery and the Montgomery Health and Wellness team cares for both patients at both the MHW Health Center and the world-renowned Texas Medical Center. So we are in for a big treat tonight. And without further ado, I'm going to turn it over to Dr. Montgomery.
Well, thank you very much. Thank you very much for that kind introduction and those kind words. And thank you to your audience and welcome. And thanks for having me tonight. It's always a pleasure to talk about an area that's near and dear to my heart. My discussion tonight is going to be on nutrition. We'll go ahead and share my screen and give you guys the title. And oftentimes we think of nutrition or lifestyle in general, nutrition in particular, is something that has that we're looking for long-term benefits from. And I think that's accurate in the sense that a lifelong practice of a healthy lifestyle give you lifelong benefits of a healthy lifestyle practice. However, the question that we frequently ask in my center is that what are the benefits of acute intervention? Patients who are acutely ill or who may be subacutely ill with advanced elevation in blood pressure, advanced heart disease of different types. Can a nutritional intervention have an impact in a very short period of time or in the immediate time to where it makes sense to add this as part of other urgent therapeutics such as medications and procedures? And so what I'm going to attempt to do is make the case for exactly that. Now, I'm going to apologize in advance because there's some technical aspects of this presentation that I'll say I couldn't avoid, but I chose not to avoid, however you want to look at it, because I think for us to really get an understanding for how nutrition can truly benefit us if we're, say, acutely ill or someone who's acutely ill, even to the point of being hospitalized, to the point of having a heart attack or decompensated heart failure, then we need to understand the underlying processes that's going on in these patients and then how nutrition affects these processes. So there's some technical components. I'm going to make sure I try to explain things, but just bear with me as I go through this. We'll summarize a lot of it, especially when we get to the technical aspects of the medical intervention. So what is acute and chronic illness? An overview. If we want to just ask the question, acute heart failure, acute, lung disease, whatever the illness is, then you want to understand the chronic nature of it. So the foundational question is, what is chronic disease? And essentially, it's an adverse health condition that is expected to last over a year. We know a lot of these. We know about heart disease, cancer, diabetes, chronic lung disease, arthritis. I listed just a few here. There are many that you could probably think about. And then there are many chronic illnesses that we don't have a name for. A patient will come in to the doctor and they have, well, I've got these sets of symptoms, and it doesn't fit into all little convenient boxes to give it a name. And so these are chronic illnesses too. They just don't fit into our nice labels that we have in medicine. So what I like to do when I think of patients, I don't like to think of the labels. From a diagnostic standpoint and communicating with the patient or communicating with other healthcare providers, we have to use these labels. But when I try to think of a therapeutic intervention, I think of the underlying process. So while the label is there, the most important thing is to understand the underlying process. And so if you want to think about the underlying process of chronic disease mechanisms in general, whether it's lung disease, COPD, or diabetes, or whatever, I like to put several fundamental things in place. One is inflammation. Inflammation I liken to a biochemical fire. It underscores many chronic illnesses that I have listed here: cancer, neurological diseases, bone and joint disease, pulmonary disease, metabolic disorders, cardiovascular disease, autoimmune, etc. And so there's an underlying inflammatory process generally that's driving a cellular defect as well as a tissue level defect that leads to progressive cellular, tissue, and then organ breakdown, and hence you have the manifestation of a disease. Next major category is oxidative stress. Oxidative stress, I like to think of as a toxic chemical buildup. Many of you have seen an apple. If you've bitten into an apple and you sit it on the counter, you'll see it turn brown and decay over time. That's oxidative stress on the apple. It's akin to what happens at the cellular level. You see a normal cell degenerate. And so if you have excessive number of toxic chemicals, we refer to them as free radicals. Excessive number of these chemicals that build up, they float around and cause damage to genetic material, tissue, cell walls, and the like. And it leads to this accelerated oxidation or breakdown. A third one that I don't have a slide on is the microbiome. It's probably another major area, and we're learning a lot about the microbiome. But I thought I would mention that, even though I don't give a detailed description of it. But the microbiome can be thought of as our local ecosystem of microbes that we live with, and they play an important role in our overall metabolic process. And so if that's off balance, it can actually lead to a lot of other imbalances, digestive problems being one, but also it can predispose to increased oxidative stress or inflammation as well. So if we think of acute chronic illnesses, mechanisms of inflammation, let's look at acute cardiac injury. So we're going to get into some of the specific aspects of injury with the heart in the context of inflammation. So how does inflammation, what are some of the mechanisms rather of inflammation and how it leads to acute cardiac injury? Well, it contributes to progression of heart failure. There are pro-inflammatory cytokines. Cytokines are molecules that behave as cell signals. They're used by inflammatory cells to signal other cells that there's an abnormal process. And so these signaling cells, molecules, can amplify the inflammatory process. There are pro-inflammatory cytokines. There's some that we look at in particular, IL-1 beta, TNF alpha. These are known to induce both systolic and diastolic dysfunction of the heart. In other words, it weakens the heart's ability to contract and impairs the heart's ability to relax. And so it also results in adverse remodeling. So if the heart is injured, say in a heart attack or an ischemic insult, when it tries to heal itself, that healing process is abnormal and can lead to worsening cardiac function. So acute heart failure is essentially a cytokine storm. And I use that phraseology there because many of us became familiar with cytokine storms and during the pandemic, when people would get COVID infection, they become very ill, intubated, they go into cytokine storm, the whole body would sort of shut down. You get increased clotting and organ failure. Well, this isn't anything unique to COVID. This happens to people with chronic illness all the time. It's the same mechanism that we're familiar with. And you can have cytokine storms that are isolated to a certain tissue bed. So if someone's having an acute heart attack, that can be a localized cytokine storm to the coronary arteries, whether you're having a heart attack. If you have a systemic cytokine storm, the person going into sepsis. And so there's a systemic inflammatory process that's going on. So this can happen in acute heart failure. The acute injury can happen at the endothelial level. If the endothelium, which is the inner cell lining of the blood vessels, if they are inflamed, one of the major things you see is an impairment of the production of nitric oxide. And so you see reduction of nitric oxide and an increase in these, what we refer to as reactive oxygen species. These are just toxic chemicals again. And this is how inflammation feeds into oxidative stress. So you see reduced nitric oxide. Nitric oxide is a molecule that is important for health of the endothelial cells. It's important for vasodilatation, and it has lots of other important roles in terms of normal biological and biochemical function at the level of the endothelium. So you have a reduction in healing molecules and an increase in toxic, non-healing or destructive molecules, i.e. reactive oxygen species, when you have inflammation of the endothelium. So here's some other components. So this molecule called titin, it's the protein that is think of this protein as a cytoskeleton protein. It's like the frame of the house. So if you think about your house, it has the frame, then the frame of the heart is this tightened cytoskeleton protein. So this protein becomes hypophosphorylated, and it results in increased stiffness of the heart. A heart that's stiff doesn't relax well. A heart that doesn't relax well doesn't fill. So if it doesn't fill with blood adequately, it's not able to eject blood. So again, nitric oxide contributes to reduction of nitric oxide contributes to stiffness of the heart. And then this other component, low protein kinase G, leads to thickening of the heart, further causing what we call diastolic dysfunction, or again, stiffening of the heart. So inflammation, and we see lots of patients come in with echocardiograms that shows the heart stiff. This is due to chronic inflammation, and these are some of the mechanisms. I'm sharing this with you because later on in my talk, I'm going to talk about some of the things we plan to look at in terms of nutrition, in terms of nutritional effects on some of these molecules. So there's a method to the madness of talking about these details. And of course, we're going to expect that all of you are cardiovascular biochemical experts by the time you leave this talk. So endothelial inflammation causes a range of other deleterious effects. There are adhesion molecules, VCAM1, E-selectin. They subsequently trigger interstitial collagen deposition, which causes scarring. There's also impairment of the small vessel function. So you have microvascular endothelial dysfunction, which results in poor blood flow. You proliferate fibroblasts and myofibroblasts. These are cells that promote more scarring, and the capillary impairment impairs microcirculation. So the heart becomes more scarred, more stiff, and the circulation, the blood supply, oxygen supply to the heart muscle cells become more impaired. So inflammation of the blood vessels wreaks lots of havoc, and these things can happen slowly, chronically over time, but in an acute flare-up, they can increase and cause an acute abnormal process. The immune system has a role. So the innate immune system, again, if you have chronic inflammation, this may be due to a poor diet, poor lifestyle. Your immune system is constantly revved up and to some extent in disarray. So this constant revving up of the immune system and constant disarray can lead to a host of things. And so there are 10 forms of certain receptor molecules that contribute to myocardial inflammation. There's myocarditis, inflammatory ischemia, perfusion injury, aortic valve disease, hypertension. So these are some molecules that on the surface of the cells that we've identified to be associated with certain valvular disease and other types of heart disease. These other pattern recognition receptors that some are designed to recognize and signal inherent cellular defects. So a cell that's has excessive oxidative stress may show a receptor molecule called a damage-associated molecular pattern, or another type of cell that may be infected with a virus or bacteria may have a pathogen-associated molecule. And so we know that the cells themselves have these signaling receptors to say, hey, I'm sick, or say, hey, I'm taken over by a bacteria virus. And that, again, triggers inflammatory reactions and triggers an inflammatory cascade. Stresses such as ischemia may induce the release of these. So if you have poor oxygenation, then you would then result in, say, a false signaling of these receptors that then will trigger inflammation, just not because the cell may be infected or the cell may be inherently bad, but just the cell is suffocating. So suffocation due to the poor blood flow and ischemia can contribute these types of receptors. So again, there's some complexity there, but what I want to try to get across is that there's some complex mechanisms that we have an understanding of. We don't understand all of it. We just understand some of the mechanisms by which these things contribute to heart failure. That's one point. The other point I want to emphasize is that these underlying mechanisms are not unique to heart failure. These underlying mechanisms are related to infection and other chronic illnesses. So there's a common denominator of acute illness and acute chronic illness based on these underlying mechanisms. Let's say a few words about oxidative stress on the heart. So as I said before, you have these toxic molecules like reactive oxygen species, and they have several detrimental effects. Number one, they can affect the electrical functioning of the heart. This is due to having an adverse effect on certain receptors, the way that the body exchanges certain electrolytes. You have exchange molecules or receptors that may trade a sodium for calcium exchange. So you can affect how this exchanger works, leading to an increased amount of calcium inside the cell that can have adverse effects inside the cells. There are other types of current molecules, sarcate, ATP currents, which can lead to action potential duration. So in other words, the electrical repolarization of the heart can be changed abnormally, leading to arrhythmias such as atrial fibrillation or ventricular arrhythmias. So the effects of excessive oxidative stress can have abnormal electrical effects. Excuse me. Reactive oxygen species can also affect certain types of receptors that inhibit sarcoplasmic reticulum, calcium, adenosine triphosphate. Again, the technical names are not important, but notice that these reactive oxygen species have an adverse effect on certain receptors that can lead to increased calcium overload that results in the ability of the heart to contract or relax. So why is the heart stiff? Why is the heart weak? We mentioned before, inflammation can cause fibrosis and scarring and stiffening of the cells, but then reactive oxygen species could be working at another level, causing stiffness by means of abnormal electrolyte flux inside these cells. Mitochondria important for many reasons, one of which is increased production of energy, ATP. So mitochondria may become dysfunctional as a result of ischemia, and their role is impaired. Increased reactive oxygen species also can cause fibrosis, as mentioned in some of the early inflammatory mechanisms. So just in summary, picture says 1,000 words. Number one, oxidative stress can result in electrical problems. Number two, it can result in the ability of the heart to contract or relax. Number three, it can result in mitochondrial dysfunction, which again impairs energy, ATP release, which again impairs the heart's ability to contract and relax, or it can result in direct fibrosis, which causes stiffening of the heart. So these are the underlying mechanisms by which we know they have an impact on chronic illnesses in general. And what I've just shared with you is how they can impact heart disease in particular. So, plant-based nutrition plan, what are the general benefits? As I alluded to earlier, we have, lots of data of the long-term benefits of consuming a plant-based diet. I'm not going to discuss that in detail here because I want to say, okay, what happens in the acute setting? But I will share, this abstract with you. It was studies showing a low carbohydrate diet from plant or animal sources and mortality among myocardial infarction survivors. So people who survived a heart attack, and so what they found is a great adherence to low cardiac diet with animal sources of fat and protein was associated with higher all-cause cardiovascular mortality and MI. So if you had a low carbohydrate diet from plants or animal sources and mortality, so low carb diet with plants versus low carb diet with animals, the low carb diet with animal sources led to more worsening mortality and after heart attack. So you did better on the plant-based diet here. So we have data showing long-term benefits, but what about the acutely ill person? How about when someone shows up in my office and they're short of breath or in decompensated heart failure, what do I need to do? So there's certain medical things that we need to do, and I'll share some of those things with you. But can a plant-based diet play a role in this patient? I mean, do we have to wait till we stabilize them medically and then say, well, once you're stable, come back, we'll talk about your lifestyle? My argument and what I'm going to share with you is that we should actually start a plant-based diet immediate. And it's not just any old plant-based diet, it's a precise prescription that we use in plant-based nutrition. So can nutrition have an impact? Let's discuss a few clinical cases. Now, again, I'll share with you some technical, and take you into the weeds of clinical management. Typically, when we present patients on this situation, this type of setting rather, we'll have a patient where I say, well, here's the patient, here's their labs before, we put them on a plant-based diet, and here's the labs after, and all the numbers look better, or medication look better. I'll do a little bit of that, but I'm going to show you some of the complexities and the challenges we have, because it's not just a simple before and after, the difficulties that we deal with in these patients. So case one, this is a patient with a condition known as cardiac amyloidosis. With cardiac amyloidosis, this is a condition where you have abnormal protein production, and they infiltrate the heart muscle tissue, causing thickening and scarring. There's a 60-year-old man, history of cardiomyopathy, ejection fraction is 25 to 30%. Normal is about 50, 55% or higher. He had a history of pulmonary emboli and DVT. So, prior to seeing us, we had this history of increasing blood clots. Now, we were, at the time of seeing him early on, were suspicious of cardiac amyloidosis, but had not confirmed the diagnosis at the time of this presentation. I don't have this echo with you tonight, but he had gone through several months of intermittent claudication that was worse on the right leg, worse on the left leg than the right. Now, he had taken some over-the-counter herbal supplement, and after taking that, his heart rate was increased. We had found him in atrial arrhythmia. We tried to control the rate with medications. But over the past week, it had, prior to this hospitalization, it had increase in severity of symptoms, which had been occurring, worsening, and he couldn't walk 10 yards. So in the clinic, we did ultrasound, Doppler study on his arteries in his leg. He was found to have an occluded artery on the left by arterial studies. And so he'd undergone adjustments in his beta blocker before that time for his atrial tachycardia, as I mentioned. But based on this finding, we had to admit him to the hospital. So on arrival to the hospital, he was noted to have a heart rate in the low 100s. They were able to get a Doppler pulse on the right lower extremity, but could not get a pulse on the left. His creatinine was 1.6, a little bit higher than it was a year ago. His low potassium. And his B-natric peptide was in the 500s. That's a molecule that we measure the amount of stress on the heart muscle. 500 actually is not bad, although it's elevated. It's not bad for someone like him. I might even say that it represents some dehydration. We admitted him to the intermediate care unit and started him on intravenous heparin. A peripheral arteriogram was done the very next day, and he was found to have multiple thrombi or blood clots in the superficial femoral artery on the left. My interventional colleague felt that it'd be best to have this surgically dealt with for a number of reasons given his cardiac condition. So the very next day, he was taken for an iliofemoral thrombectomy, which is fancy words for just surgical removal of the clot. They also found some peripheral vascular disease that they bypassed surgically. They did a medial fasciotomy with skin closure and wrap. So he had about 1 liter of blood loss. He received 2 liters of crystalloid and some albumin. So a little bit of a bumpy course post-operatively. They consulted the nephrologist, the kidney docs, because of elevated creatinine to start with. He had a loss of his pulse on the left, and they got an emergent CT angiogram with his creatinine being up, and it made the kidney function even worse. He had some increased pain, which was controlled by narcotics. They were able to Doppler the pulse later on. So he was given a unit of packed red blood cells because hemoglobin had gotten down to 7.8. It's important for these patients with heart failure and some peripheral vascular disease to make sure they have a great amount of hemoglobin red cell carrying capacity. The next day, his creatinine level had kept going up. An increased creatinine means a decreased kidney function. In other words, the kidney function went down. I'm going to show you some graphs summarizing all this. The lactic acid was building up. It was 2.4, which, you know, and it went down to 1.4, but then it went back up eventually. His creatinine kinase went up. Hemoglobin bounced around, is down, back down to 7.8 after it received, well, before it received 1 unit of packed red blood cells. The next day, I decided to give him more packed red cells, and he was oozing from the wound sites. We held the heparin, gave him some fresh frozen plasma. His blood pressure dropped a little bit, so he started on norepinephrine, and he had more lower extremity bleeding. So we lost the pulse in the lower extremity. As one Saturday morning, I was rounding on him, and his leg was very tight and tense. It became numb and pulseless. And so we diagnosed him with compartment syndrome, called the surgeons. And the surgeons came in and they actually took him down and had to open up that wound to relieve the compartment syndrome. They were concerned about him possibly losing that extremity. But I felt we had diagnosed it in time and got it. So you see here, patient calling 911. The patient, you know, again, had a little bit of delirium. He was, you know, agitated. And so his cell phone, he called 911, although he was in the hospital ICU. But these are some of the things we deal with, you know, in the setting of patients, and there's a lot of commotion and things going on. And I just want to give you a flavor of that because I think it's important. So my colleagues were asking me if we needed advanced heart failure. I felt not, because this atrial tachycardia was due to a flutter. And he had been in this for a while. We were trying to control his rate. We felt he would need a cardioversion, but I felt this is a large part of why his renal function is getting worse. His cardiac output was low. And just remember, this patient just gone an urgent surgical procedure. Anytime you get surgery done, you contribute an insult to the body. So if you have borderline heart failure, borderline, you know, cardiac output, et cetera, that insult will make everything worse. So the worsening renal function, in my opinion at the time, was more of a factor of worsening cardiac function than it was worsening intrinsic renal function. So I call my colleague, I'm an electrophysiologist, but I have her do all my procedures now. I've been doing invasive procedures for over 2 decades, and now I send them off to colleagues to do them. So she took them to the lab actually the next day, and I'll go through that in a minute, to do the ablation. But as I said earlier, the surgeons opened up the left lower extremity wound, evacuated blood and hematoma, and that relieved the compartment syndrome, and that was important. So that acid buildup from the compartment syndrome was also contributing to this overall problem. Again, as I pause here, I want you to get a sense of all the different complex things, the different moving parts that are happening. Okay, here's somebody that had a blood clot to the lower extremity, already has heart failure, which compromises cardiac output, which results in poor renal perfusion, baseline renal dysfunction. Now you have this insult with increased acid, tissue damage, increase, where every time you have lack of blood flow and ischemia, you have increased oxidative stress, increased inflammation. So these things are sort of happening as a buildup process. So he went through the wound washout, relief of the compartment syndrome, and did well. He went to the cath lab and underwent aflutter ablation. Now, again, my hat's off to my colleagues. Here's somebody who's acutely ill, and she's taken to a lab to do a procedure that normally we think of as elective. But in this case, this was not an elective procedure. It's atrial flutter, and they eventually found atrial tachycardia was contributing to his acute illness. And so I commend her in taking him to the lab and doing this procedure. The next day, nutritional detox had been initiated. Now, I tried to initiate it before that. I got into a little, head bumping deal with the nephrologist. She didn't want him to have coconut water, and they had him on a renal diet, which has animal protein. And I said, nope, I'm the attending. He's going to be on raw detox. And we were, and I explained this to the family, et cetera. So the creatinine was almost 5, and I'll show you those numbers. This was at a level where he was almost at the point of needing dialysis. We want to hold off on that. So basically, we gave him a diuretic and we gave him some packed red cells, and we, chose to hold off on dialysis. We started him on a nutritional detox regimen. I'll share some of the details of that later. There was an issue with the urinary tract infection. He was started on some cultures were taken. I think they were given some antibiotics for a brief period of time. White blood count had come down. An echo was done. His ejection fraction was less than 20%. Again, it was higher than 20% before that, but it had dropped some. He had severe left ventricular hypertrophy. That was something we found. There was no clots inside the heart. That was important to know. The following day, we started noticing things turn around. Well, actually, between the 29th and the 30th, and I'll show you the numbers that correlate with that. The swelling, edema, and things like that had improved. We, got him up out of bed. We continued the heparin drip for that point in time, although he was having some oozing. We continued to hold some of his beta blocker therapy because blood pressure was a little bit tenuous, but he was able to transfer out of the CTU back to the IMU. So we saw him improving, starting to turn the corner here. So after the ablation, they found an atrial flutter and atrial tachycardia. He was awake and sitting up in bed. He started having frequent bowel movements. This is about 4 days into the detox. He started feeling short of breath when he walked, but he was up and walking then. His pain was under control with pain medications. And we had a wound vac in place in the lower extremity. So by the 4th, so this was about 8 days after starting detox, he was able to go home, tolerating oral diet very well. So let's look at the hospital course. And again, I'm getting into a lot of details here, and there's some of the weeds. So let's look at the creatinine and the kidney function. So creatinine and GFR. Creatinine, for those you don't know, is a molecule that we measure in the blood, and the higher that molecule is, the worse the kidney function. The GFR stands for glomerular filtration rate. The effective glomerular filtration rate, the lower that number is, the worse the kidney function is. So when he came in, he did not have normal kidney function, as you see here. Normal is really above 90, but if you're above 60, you're okay. But he didn't have that. He was a little bit compromised. Now that was a large part because he had this arrhythmia and heart failure. The arrhythmia he had worsened his heart failure. So that's why he came in with some borderline or mildly abnormal kidney function, and he got worse after the surgery. And so after the surgery, and then, all the complications related to that, compartment syndrome, having to go back to the OR, all these things have contributing complications. So at this time on the 26th, he started the flutter ablation. We started the diet here, but there was some confusion. So really it wasn't the 27th that he started the diet without any interruption. So I highlight these times to show that after these two salient events, his renal function, creatinine went down, and similarly here, renal function improved. And that's an important thing to know. Now, other things were impacting his overall care. The revascularization to the lower extremity also contributed to that. Lactic acid, as you said, he had lactic acid buildup related to the lower extremity. That had decreased. Liver congestion, which is indirectly a sign of more heart failure, that had improved after the ablation and the nutritional detox. White blood cell count, it came in the normal range. It went up due to inflammation. It improved after the detox and flood, but never really did go back to normal, largely because he had a healing wound and some other things were going on. C-reactive protein is a molecule we use to measure inflammation. That had improved, but again, did not normalize by the time he was discharged, largely because there was still an ongoing healing wound process, and our nutritional detox continued even after he was discharged. Albumin level drops when inflammation goes up. And again, the albumin dropped here significantly and stayed down because, again, the inflammatory process continued. So again, a lot of details and nuance in here. Let's kind of put this picture together. Key reason for the patient decompensation. Now, he had been on a plant-based diet and been very compliant. So this patient very compliant. My PA was following him, and he was eating cooked plus raw plant foods. Now, I'm not going to bash cooked plant-based diet, but with someone with advanced disease, they need to be at a higher level of nutrition. And I think that predisposed them to a hypercoagulable state, et cetera. The herbal over-the-counter tea may have done something to him and triggered this arrhythmia. I'm not sure. I don't know what that was. He didn't remember. But something happened that caused this arrhythmia, and that predisposed to the embolization, which set off this cascade of events. So the need for vascular and diagnostic surgical intervention, again, surgery is beneficial. We saw it probably saved his leg. It did save his leg. But the insult that has to happen going in and invading the body to repair the body has its own impact. And that's why patients, before they have surgery, have to get surgical clearance, because every surgeon knows that when they go in, they're going to put a certain amount of stress on the body, and they need to do something to make sure that the body can withstand that stress. Key reasons for its recovery: urgent and emergent revascularization. So the same thing, the surgical revascularizations on both sides of the coin. It's potentially harmful and also potentially helpful. And surely it was helpful here. But getting rid of the arrhythmia, I think, was a key factor, and also the nutritional detoxification. As I saw after those two events, his condition improved, and this patient continues to improve as an outpatient. He had a skin graft over that area, and we're looking at performing a long-term nutritional detox in this patient. Then we go to case 2. Now that first case was a little bit more complex than the other two. However, they also have some nuances. So this is a patient who was hospitalized, a 66-year-old lady with congestive heart failure. Now her condition was severe mitral regurgitation, or leaky mitral valve. She had an electrical abnormality called an intraventricular conduction delay that probably contributed to some of her heart failure. But her condition worsened over a period of weeks. Now, she had been following a quote unquote vegetarian, vegan diet, but she would grill stuff and have oils and things. So she wasn't as compliant on our plant-based diet that we prescribe. So again, all plant-based diets are not equal, especially when patients are acutely ill. So the echo, I don't have her echo image here, but it showed severe leakage across the mitral valve. So she was admitted to the hospital, and the plan for her was to try to repair that mitral valve non-invasively using what's called a mitral valve clip. She was started on intravenous diuretics. She had some episodes of worsening arrhythmias while in the hospital. We had to transfer her from the IMU to the CCU for closer management. So her hospital course fluctuated just due to arrhythmias and various other components of decompensation. And again, these fluctuating episodes of arrhythmia, remember the mechanism I discussed earlier: increased oxidative stress can contribute to abnormal rhythm problems in the heart, such as atrial fibrillation, other tachyarrhythmias, or ventricular arrhythmias. And that was what was going on with her. So her abnormal biochemical milieu was contributing to her decompensation. So the structural heart team was consulted to evaluate her mitral valve clipping procedure. They followed over a few days, and just based on seeing her waxing and waning clinical condition, deemed that she was too sick to undergo this procedure. One of my colleagues who I trained under actually was a very talented structural heart cardiologist, very talented intervention cardiology of all types, just felt that he couldn't help her and thought we should just let her go home and die. I talked to my colleague, EP, because she does my devices now. I said, well, look, I felt she'd benefit from a biventricular pacing device. I felt she'd benefit from both, to be honest. But she felt that, and she read other colleagues' notes, said, look, he's too sick, she's too sick. And so she didn't want to proceed with a biv pacing procedure. And I understand, I don't want to push colleagues into doing procedures they're not comfortable with. So they deemed that she was too sick to undergo this procedure. So what we did, we called a palliative medicine team. And so they evaluated her. We got her condition optimized. We had made arrangements for her to go to outpatient hospice. And she was on an intravenous milrinone infusion, as you see on the medication list. And we were initially told that they can manage that in outpatient hospice. I don't know where that misrepresentation came about, but that wasn't the case, because she had to be readmitted within about 24, 36 hours with decompensation because they couldn't infuse the milrinone. So we brought her back to the hospital, restarted to IV milrinone. And so the palliative medicine team came back and said, well, look, and we can't give you IV milrinone in the hospice. So we're going to have to stop it here in the hospital and let you die here. And the patient was all teary-eyed. I went to her at the bedside, and she said, yeah, they're going to let me order my last meal. I'm about to die. And she started crying. And I said, well, shut up. We're going to detox you. And so we discussed things. I discussed things with the hospital management team. And we said, look, just give us a week and we'll put on a nutritional detox. And the plan was to detox her enough to reduce oxidative stress, reduce inflammation, and improve cardiac performance so that she didn't require the milrinone or other medications. And essentially, she underwent a successful detoxification and weaning on the IV milrinone and other medication within 7 days, and was discharged home to home hospice care instead of going to inpatient hospice at home. She was discharged home on just one medication, which was only on an as-needed basis for weight gain. And so we'll look at the clinical data. And so the hospital course, hers is a little bit more complex because she went through the hospital course. Now she was on milrinone, and that improved some of her function, the IV diuretics initially in milrinone, but then she had some arrhythmias that made things worse. Now this is a creatinine. So as the creatinine goes up, kidney function goes down. So think of this graph as the following. When these numbers come down, that means kidney function goes down. When kidney function goes down, that means heart function goes down because the heart perfuses the kidney. So we can look at kidney function as an indirect barometer of heart function. And as the creatinine went up, i.e. kidney function went down, and again, creatinine goes down, kidney function up, and so on and so forth. So her function bounced around, and we got her ready to be discharged. The creatinine was down to generally a normal level. I would say this lady was fairly thin. And so I would say normal for her would be more like 0.5, maybe even 0.4. So even though these numbers are within the statistical norm, they probably weren't normal for her, but nevertheless, they were better than they were at some phase during the hospitalization. So, but she wasn't able to stay on the milrinone. So she was doing okay on the infusion of milrinone. Milrinone, by the way, is a medication that causes the heart to contract more forcefully, and it improves cardiac output, it improves cardiac performance. So therefore, it can improve circulation and improve overall condition in somebody with congestive heart failure. So we weren't able to use the milrinone, so we had to bring her in. And this is where the detox started with her. And so we detoxed her, and then we saw where the creatinine went down, i.e. the renal function went up. But the important part here is that this improvement was also associated with removal of medication, including milrinone. The other labs here, detox here, here's the GFR. So again, the GFR is up at times when she's on milrinone, and that's a normal perfusion. But when we had to stop the milrinone, the GFR came down. So we started on detox, and the GFR went back up, not necessarily as high as when she was on milrinone, but it was up in the normal range. So renal perfusion was adequate enough to get her off the milrinone. Similarly, lactic acid or acid production went down over time after detox. Liver congestion, which was decreased on the milrinone, stayed down despite being off milrinone on the detox. Again, more liver congestion staying low. Again, better cardiac performance. White blood count did something kind of funny. It went up before coming down. So she could have some kind of a detox reaction here. I'm not sure what that is. We do see increased inflammation transiently when someone starts a detox and it goes down, but she was released with a white blood count that was significantly lower. So, but the clinical picture here is most explained and underscored by the medication changes, because again, this particular one medication limited her from going home on hospice. And so the detox was able and enabled us to not only reduce this, but reduce her requirement for diuretic. And she had, I didn't mention earlier, she had a history of lupus. So she was on hydroxychloroquine, and her intermittent lupus flares may have been contributing to some of this, but we were able to take her off the hydroxychloroquine and some of the other, the atrial, the sotalol, which was the atrial fibrillation. We were able to stop all these medications. And I was aggressive in stopping the medication because I want to minimize any kind of congestion on the liver. So in other words, she was discharged on one medication. So the baseline 6 went down on 1. This allowed her to go. and do quite well at home. So why did she decompensate? She was on a suboptimal plant-based nutritional regimen at baseline. She had severe mitral insufficiency, atrial tachycardia, cardiac condition was abnormal. Conduction abnormality, which probably led to dysynchrony in the cardiac function, which led to worsening of her heart failure. And she had systemic flare of her lupus, which was probably underscoring a lot of this. Key reason for recovery: nutritional detox and medication weaning. I don't want to underscore the importance of weaning medication. Medication can have toxic effects on the body, and we are very aggressive about weaning medication, as aggressive as we are about weaning, bad foods. We're aggressive about weaning unnecessary medication to the extent that we can. Our last case I'm going to discuss, not quite as complex as the first two, but still has some important components that I think is important for us in this discussion. So this is a gentleman who is 76 years old, had a history for diabetes, prior strokes. He had lower extremity blood clots, DVTs. He was currently on anticoagulation. He was seen and had a chemical stress test back in 2019 at one of the local hospitals. And he presented to an outside hospital. So there's another cardiologist doing this assessment. He had symptoms of mild chest discomfort. He had associated symptoms of not feeling well, some nausea. The EKG showed some significant abnormalities that were concerning for an acute coronary syndrome. Some diffuse T-wave inversions. He was started on IV heparin and taken to the cath lab emergently. Excuse me. So this is a patient presenting in the throes of a heart attack in an outside hospital. So heart cath showed diffuse multivessel coronary artery disease. And the surgeon at the time felt that due to the multiple vessels of coronary disease, multivessel coronary disease, and he felt his ejection fraction was borderline normal. He felt he'd benefit from emergent bypass surgery. The family reached out to me through our answering service and wanted me to take over the care. So we were able to, after making a few phone calls, get him transferred to the hospital, the Texas Medical Center. And so it took a little bit of work, but we got him transferred over. So I evaluated him along with my surgical colleague. And instead of going for emergent surgery, we felt that it'd be best to give him intravenous heparin, watch him for the course of a week, and see how he does. My surgeon was, we're aggressive, but we also cautiously aggressive. And we don't like to take patients unless they're decompensating, really needed for emergent bypass. I also asked one of my interventional colleagues to look at his coronary angiograms, and he felt against PCI as before. So we were going to have him on IV heparin and leave him in for a week. However, the patient had different plans. He says, I want to get out of here. So that's against medical advice. Within 24 hours, within about 24, 36 hours of transfer, he went home, probably moved around and did whatever too much and got sicker at home. And so he came back within 24 hours of being discharged. When he went to the emergency room, his ejection fraction a little bit lower, his blood pressure was low, had to give him fluids and whatnot. So the surgeon was definitely not going to touch him here, and same with the interventional cardiologist. So what do you do with a patient who's having a heart attack and is too sick for surgery? Well, you detox him. So what we did is that we started him on detox the latter part of 6-1 and beginning of 6-2. That's why I highlighted these. Cardiac troponins, the molecule is elevated when you're having a heart attack, and his came down. Now this could have come down on its own. So whether detox affected that, who knows? His BNP, which I mentioned earlier, causes as a sign of myocardial stress, went up. Now, someone with heart failure like this patient, so his ejection fraction dropped around 30, 35% after he came back. I felt that he was a little bit dehydrated. And so we put him on raw fruits and vegetables only, green smoothies. He was able to have some salads to the point he was able to chew it. But nothing cooked, no animal protein, etc., no processed drinks. And I think his hydration level picked up to where his BNP went up. So that's my explanation for that. His kidney function bounced around. It was a little bit elevated. Remember, the creatinine is up. That means kidney function's down. So it did bounce around and improve some before he was discharged. And this is someone who had, IV contrast, which does compromise kidney function. The glomerular filtration rate also improved after detox in this patient. And the lactic acid level eventually went down. We saw increased lactic acid level in this patient. Again, the white blood count, which was elevated, that's a sign of inflammation, did decrease. And even though it was in the normal range here, I don't think it came down to normal for him. So I think even though we discharge him with a normal white blood count, I think his normal is probably maybe 4 or 5, and we probably weren't there because he had some inflammation going on. Albumin continued to drop a little bit, not a huge amount, but still down. That's related to inflammation. He did have some increased liver congestion that improved over time. And so what's the overview with this patient who was too sick for surgery? Well, key reasons: consumption of standard American diet. Is an older, cantankerous man. His daughter really worked hard and bought meal plans for him, and he was still sneak and eat bad food. He had advanced atherosclerotic disease, hypercoagulable state, and I think the biggest illness was the stubbornness and noncompliance. But the recovery while he was in the hospital, he had to comply in a nutritional detox. I think the bed rest did help. And again, we did wean some of his medication. We weren't able to wean as many as we like, but again, a small amount of medication weaning allowed him to recover. Again, this is an elderly, the 76-year-old man in the throes of a heart attack and a weak heart who was too sick for surgery, too sick for angioplasty, was not only stabilized, but clinically improved to the point of going home, is up walking and talking and doing pretty well. So that's some of the data we have, or excuse me, the clinical examples we have. We say, okay, well, that's all well and fine. What is some of the mechanism? I alluded to mechanism in terms of how chronic illnesses occur and how they can become acutely flared. What have we shown in some of our studies? Well, we've looked at patients with chronic illnesses. So there's a group of patients with hypertemperature, hyperlipidemia, and increased BMI. And these are conditions that are known to be associated with increased inflammation, oxidative stress. And so we applied a defined plant-based diet, that's a raw plant-based diet, and followed the changes over the course of 4 weeks. And as we all suspect, you see an improvement in weight and BMI. And so these things are not surprising, but the white blood count was reduced significantly. These p-values are less than 0.05. These are less than 0.0005. Shows that this was statistically significant across the board here. And so we saw a very significant reduction. And actually, some of these reductions were significant from week to week. So this B superscript shows from here to here was greater than, less than 0.001, and this was less than 0.01 for that, and this is less than 0.01. So you saw very significant reductions in white blood count each week. So these were changing. So we know that these changes are happening on the orders of days. It's important to keep in mind in light of the clinical case I presented to you earlier. Systolic and diastolic blood pressure improved in a matter of days. And again, from week to week, it improved. We have other data from studies we've done before showing that vascular resistance, reduction in vascular resistance is part of the mechanism in this reduction in blood pressure. We know that stroke volume goes up from other data, some of our heart failure data. And the requirements of medication was reduced significantly. And again, this is not a trivial matter because patients who have chronic illnesses may have liver, hepatic dysfunction, as I showed you in some of the abnormal labs. And if you're taking medication, it has to be broken down by the liver, and the same liver or kidneys, and the same kidneys compromised by poor circulation, the liver is compromised by poor circulation, and then you're having to take a medication that's further compromising the liver and kidney. It makes things worse. So being able to wean medication is an added benefit of a nutritional detox, even in the acute setting. And I would even say, especially in the acute setting. And so the heart rate went down, other prescription medication went down, which is important, et cetera. So generally looking at hemodynamic anthropometric effects, we see very positive changes, which can explain what we see. Now, here's some data from a case series of heart failure patients, which we had 3 patients who underwent a defined detox. in about 78 days, we saw, in 78 days, the change may have happened before 78 days, but the average number of days on the before and after cardiac MRI showed an average ejection fraction from 22% went to about 44%. We saw regression and thickening of the heart muscle, so regression in LV mass, increase in stroke volume, which is the amount of blood, volume of blood that's ejected with each contraction or each heartbeat, and the cardiac output, which is circulation, volume of blood circulated throughout the body per minute. All these things improved, most of them significantly. What about some of the inflammatory processes or, well, the anti-inflammatory effect? For years, we've been seeing a greater than 30% reduction in C-reactive protein. We just reported it about 4 or 5 years ago, but I've got data going back, more than a decade of patients going through our nutritional boot camp. We measure CRP, we see 30% reduction across the board on average. Inflammatory cytokines, 23% reduction. Remember, cytokines are some of these molecules that triggers more inflammation, the cytokine storm, if you will. We see that this can be decreased with raw plant-based food. Plaque2, a vascular inflammatory marker of sorts, reduced by 16%. Fibrinogen similarly reduced white blood count, as I mentioned earlier, 20. These are very significant reduction in just 4 weeks. Okay, this is just 4 weeks. And we saw with the white blood count, we saw week-to-week changes. Lipids, we know, can be reduced significantly over the course of a few weeks. Insulin levels also reduced. Notice the glucose level. Now, these are biomarkers, metabolic biomarkers. Glucose, fasting glucose remain unchanged. But guess what? Hemoglobin A1C. So hemoglobin A1C, as many of you know, is the average glucose over the course of 3 months. And so you say, well, we're looking at it in 1 month. So how do you see a significant change in 1 month of a parameter that's measured over 3 months? And the answer is that there are 2 factors that can influence, 2 primary factors that influence hemoglobin A1C. One is the average blood sugar. The other is the fluctuation of the blood sugar. And so it's my theory that we reduced the fluctuation of blood sugars that was so great that in just 4 weeks, we saw a significant, about a 3.4% reduction in hemoglobin A1C. Now, I want to point out, these people had an average hemoglobin A1C of 5.9. That's a pre-diabetic group. The smaller or closer to normal the number is, the harder it is to show a change. Now, if these are people who were diabetics, this was not a diabetic group that we recruited, but this is a group of diabetics who had an average hemoglobin A1C of 8, 10, or whatever, to show a 3% reduction. Okay, that's one thing. We're showing a 3.4% reduction that was statistically significant in just 4 weeks in a group that were not diabetics. I would argue that if we recruited diabetics who have an average hemoglobin A1C of 8 or 9, we'd see a much greater percent reduction in just 4 weeks. C-reactive protein, again, as we showed before. So again, some important parameters here. We have future clinical investigations, and I'm going to go over this pretty quickly. I know I've been talking for a while. I don't want to bore you, but I will say that we're currently looking at comparing the defined plant-based nutritional regimen to the Mediterranean diet. It's going to be a randomized study. This would be a population of people with known coronary disease. And we're going to look at the clinical effects as well as biochemical parameters. We'll look at the anthropometric measures, medication count, echo, EKG stress, continuous monitoring. So we're going to look at arrhythmias at baseline and follow-up. We're going to look at lipids, C-reactive protein, comprehensive metabolic panel, LP(a), pulse score. These are all biomarkers we do in the clinic. We'll do a health questionnaire. We'll do 24-hour dietary recall. We'll do serum biochemical analysis. We're collaborating with Georgia State University, and they're going to look at biochemical markers, IL-6, IL-1 beta, TNF alpha, nitric oxide, look at antioxidant activity, polyphenol analysis. We'll look at polyphenol analysis in the blood as well as in the food of the patients. And macro and micronutrient assessments of the food as well will be done. So now we're going to look at the effects of the clinical effects. We're going to look at biochemical effects. on the patient, and also look at the biochemical effects of the food. So I'm not seeing any studies look at these things as extensively as we'll be looking at them. Monocyte and leukocyte isolation and analysis. We'll also treat human coronary endothelial cells with the blood before and after the intervention, and look at endothelial nitric oxide synthase activity, intracellular nitric oxide concentration, reactive oxygen species release, pro-oxidant and antioxidant enzymes, inflammatory enzymes will be looked at. We're also going to look at on the microscope gene expression, myocardial cell hypertrophy, and these are going to be in human myocytes, cardiomyocytes that have been isolated. Look at the sarcoplasmic reticulum stress. Remember earlier in the mechanism I talked about how oxidative stress and inflammation can lead to increased calcium influx, and there are certain enzymes that's produced by sarcoplasmic reticulum that we can look at these effects mechanistically and make correlations and look at pro-oxidant and antioxidant enzyme and inflammatory enzymes. So we're going to look at these detailed mechanisms in this context of study. So not just, okay, eat the food, oh, you lost weight, blood pressure better, oh, that's great. But we're going to look at those things and try to correlate them with the detailed mechanisms at the cellular level. A quick word about the food. They're not just eating lettuce. I just want to give you a picture's worth 1,000 words. This is a sample of a beet burger, a side salad, corn chips. These are all raw detox food. There's a sprouted rice, salad on the side, nori rolls. There's a Hulk burger. We make dehydrated onion rings, which are delicious, and then a whole host of other things are better than tuna. Sandwich is a crowd pleaser in the Garden Kitchen restaurant. They'll receive some superfoods, and many of our patients in this detox receive superfoods in addition to some of these foods. So the patients who are in the hospital receive food from a nutrition center that didn't eat the hospital food. This is what they were eating while we were detoxing them. Many of them had smoothies only, smoothies plus salads, etc. And we do this on a routine basis. So final thoughts, the food prescription vision. The benefits of leading a healthy lifestyle are universally accepted, at least by those of us who are rational minded, I like to think. But the benefits of plant-based foods are generally rationally accepted. And I want to make an argument, that point, second bullet point, even on keto diet or paleo diet, et cetera, all these other so-called healthy diets, which I don't think they're healthy, Mediterranean diet, all of these diets have plant foods. And so even if you make the argument, if we just step back and concede, okay, Mr. Paleo, Mr. Keto, whomever, we'll grant that your diet is healthy, but your diet also contains plant foods. And the plant-only diet is healthy, and it also contains plant food. So the sine qua non of a healthy diet is plant food. So we can say that pretty easily, even though diets that I truly don't think are the healthiest diets, which may be, animal plus plant diets. Some people can have improvement initially on some of these diets, but they have to have plants in them. So the application of a healthy nutritional lifestyle in clinical medicine needs more precision. It's not enough to say, okay, eat plants or eat vegan, et cetera, because people, it's how do you prepare your food? Where do you get your food from? Et cetera, et cetera. And so when you, in a situation where patients have very little room, a margin for error, then it's important that you are very precise in what you do and how the food's prepared. And our vision is to develop nutritional interventional processes with scientific validation that will contribute to greater understanding in this area. Thank you very much for tolerating this long and technical discussion. I'm going to stop here.
All right.
Open the floor for questions, comments, smart remarks, insults, et cetera, et cetera.
We got a comment from Ganesh. She says, great to see you, Dr. Montgomery. I did a 28-day detox program last year, levels 0 to 3. I did blood work before and after the detox and experienced big improvements with an 80% drop in inflammatory markers and a 40% drop in LDL. Thank you, Dr. Montgomery. That's amazing.
Yeah, thank you, doctor.
Thank you. Thank you. Great, great. Thank you very much for that.
And I was referred by Venkata Vedam. He runs a Facebook group. And so I did the detox. I saw great benefits. In fact, in Chicago, we did a Baxter get together.
Yeah. I remember that. Yes, good deal.
Yes.
I remember that. Good job. Yeah, the online detox.
That's right. Thank you. Thank you.
All right. Phil, would you like to unmute and ask your question?
Yeah, thanks. I just have a couple questions for Dr. Baxter. The first one is on a slide early in the presentation, you showed where a low carbohydrate animal-based diet and a low carbohydrate plant-based diet had differing outcomes. And I wondered why there was an emphasis on low carbohydrate, because to me, when you showed some of the foods that it appeared to be in your nutritional detox diet, they seemed to be adequate carbohydrate. So that was my first question. The second question is, on the list of medications that you removed, vitamin C was in there. And I was curious as to why you felt that needed to be removed and whether it was actually doing any damage.
Great question. I'm going to get the second one first. It's quicker. I didn't point it out. The vitamin C that she was taking was an over-the-counter vitamin C, so I wasn't certain about it. We do supplement vitamin C for our cardiovascular patients. We have a liposomal formulation, and she had been on something over-the-counter that she was taking, and we discontinued it. I actually give vitamin C intravenously in the hospital from time to time, so I use it. That one was removed, if I remember correctly. It was an over-the-counter formulation, over-the-counter supplement, and not a professional formulation. And so I removed it. We probably later on put her on something that was more professionally formulated. She had some limited resources and wasn't able to afford some of our better supplements. So frequently I just say, well, better to do no supplements if you're not going to do, quality supplements. The first issue, that study with the emphasis was low carbohydrate diets, and that's the way they designed the study. And I think it's interesting because so if someone's on, so hypothetically, let's say if we did a study, hypothetically, put somebody on a vegan diet and somebody on a keto diet, and so keto diet is low carbohydrates. And let's say, you free them on a vegan diet. So maybe they could have, vegan donuts and vegan breads and vegan whatever, vegan processed carbohydrates, but they're not consuming animal protein. And then the keto people are consuming too many animal fats and low carbohydrates. You can argue that there's some benefits on both sides, even though I would say the vegan diet will win out over the keto diet, but there's some harmful effects on the carbohydrates. So then if you say, well, if we do a study and we think that low carbohydrates have some benefit, but the keto diet is not good because of the animal protein, then let's do apples to apples, reduce the carbohydrates on both sides and have one consume animal protein and one consume plant protein. Then let's see what happens. So I don't want to try to get into the minds of the study designers, but if you wanted me to render a guess, that would be my guess as to what they were trying to do. Is and there are people who talk about vegan keto diets. There are some people with certain conditions, systemic, candidiasis or cancer, where you restrict, fruits a great deal. And you say, well, okay, is that a keto diet? I mean, because that's really a combination with, people with keto. I mean, you can't really take carbohydrates out at all. I mean, pistachios have carbohydrates. I mean, so you can't totally eliminate it. My opinion is that, adequate carbohydrate diet, an adequate diet, look at the macromolecule breakdown, is going to have predominant carbohydrates. I think it's going to be hard to go below 50% carbohydrates, with an adequate diet. You probably need 60, 70% carbohydrates. And the study we did when we looked at our nutritional regimen, it was about 20% fat, 8% protein, about 72% carbohydrates. And those are the changes you saw in that nutritional regimen. So somebody asked about services. You put in the chat some information. We can, if you want to repost that, I don't know.
Yeah,
okay,
if you go
website.
to the top up here, I've got all of Dr. Montgomery's websites, like the online, the coaching, all that information is up at the top of the chat box.
Yeah, and you can call our office, however you want to do that. We've got online coaching and the website. Did he give you that flyer that had an email on there also?
Yes.
Wellness at Heart Diet?
Yeah, but this is it right here, but that's I don't know if it's backwards on the thing, but
Yep.
that's what I typed into the chat box there. And I think we can probably email this. I think Marion, I'll send a message to Marion to email all of this
Okay.
information to the participants tonight.
Perfect. Thank you very
So,
much.
yeah. Do you have time for one more question?
Sure, absolutely.
Okay, well, Charlene wants to know what were the details of the Terry, the details of the detox diet. And I have a quick question for you. Do you ever try broccoli sprouts?
Yeah,
on
the
this
answer to
patient?
broccoli sprouts is a quick yes. And the details of so the first patient with the amyloidosis, he was on smoothies, coconut waters. We gave him a super green powder with the smoothies. We also had him on, he was able to eat solid. So we had him on some dehydrated food. So he would have beet burgers. He had some of the onion rings, I think. He was also consuming a lot of the salads. We have a sprouted wild rice that we mix with things. So there's a savory component of it. So he was having savory foods in addition to the smoothies and detox foods. The patient with the heart failure, the severe mitral valve regurgitation, she was strictly on smoothies. I put on a raw smoothie feast. So she had no solids for like the first 4 to 5 days. And I started adding a few salads toward the end before she got out of the hospital.
What's in your smoothies?
So the smoothies that she had, we had beets. She had some with beets, kale, spinach. We would put blue green algae, E3 Live in all of the smoothies that she had. All the smoothies the other patient had E3 Live, blue green algae. And we have a power greens that has a lot of dehydrated greens, broccoli and organic dehydrated, freeze-dried organic greens in it. So we're giving them lots of compact amount of super greens that improved her overall condition over all of them. And again, that's a therapeutic effect of reducing inflammation, reducing oxidative stress. As he's somebody who's a husband of the EP.
Yeah, excellent. Pass the word along.
Thank you. Yeah, so.
All right. Well, excellent. Well, I think that's it. And Dr. Montgomery, thank you so much for your time and such a detailed presentation. I mean, that's just amazing information. And it's so exciting to people like Terry's husband and myself with a heart failure background. I wish there was someone like you in Arkansas. So
no problem. But real quick, I mean, you're a cardiac nurse. I know your answer. You ate this up. Just to hear from the audience, was this? I mean, thumbs up or down? Was it that? Did I get the message across? It was too many details, too technical, et cetera, et cetera. This is a new talk, so you guys are part of the guinea pig. So, was this digestible information?
We've got a nurse practitioner. It was perfect for Terry.
Well, you don't count.
You don't count. Non-medical people. What did you think?
Oh my goodness.
Well,
but anyway, just give me feedback on the email, what people think.
Phil says, thank you, great presentation. My iPod says wonderful presentation. Let's see, it was detailed and good.
Okay, good.
I don't see anyone complaining. Thank you, doctor. Thank you for your amazing presentation. So
appreciate it. Well, thanks for your great input, and keep up the great work you're doing. And let me know if I can be of some help sometime.
Oh, absolutely. If I ever make it to Houston, I'd love to come visit your clinic.
Please do. Please do. Y'all have a good night.
Thank
All
you.
right. Thanks so much, Dr. Montgomery. And y'all, thanks for attending tonight. Take care. We'll see you later.